Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
It is the policy of Medscape Education to avoid the mention of brand names or specific manufacturers in accredited educational activities. However, trade and manufacturer names in this activity are provided in an effort to provide clarity. The use of brand or manufacturer names should not be viewed as an endorsement by Medscape of any specific product or manufacturer.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Welcome to this Medscape program titled Beyond PSMA, Preparing Your Practice for the Next Generation of Prostate Cancer Biomarkers. I'm Karim Fizazi, medical oncologist from Centre Oscar Lambré in Lille and University of Paris-Saclay here in France. So this is a multi-chapter program consisting of 3 chapters. First, we will look at the changing landscape of biomarkers for men with prostate cancer. And second, we'll look at biomarker testing for these patients, current practice, but also what's next with Professor Tombal. And finally, we'll discuss the best practices for multidisciplinary care of these patients, also together with Professor Tombal and Professor Briganti. So let's start. We are all familiar with targeting the androgen receptor axis. We're doing that for basically a century with hormonal therapy, either directly or indirectly. But more recently, we've been targeting a new protein called PSMA. And this is because PSMA is a quite specific protein for prostate cancer. It's a transmembrane protein that can use for imaging purposes with PSMA PET, which is probably the most sensitive technique that we currently have in this disease. But we can also target PSMA for therapeutic purposes using, for example, lutetium PSMA, but also many other weapons, such as actinium, T-cell engagers, ADCs, and others, which are currently under research. All right, that's very nice, but actually there is much more coming and already together with us. For example, an important minority of patients, approximately 20% of patients with metastatic hormone-sensitive disease, have PTEN deficiency. So what is PTEN? PTEN is actually a protein which is a gatekeeper for the AKT-PI3 kinase axis. So in other words, if the patient or his tumor doesn't have PTEN, this axis is activating the cancer cells in parallel to the androgen receptor axis. So for these men, theoretically at least, we should target both axes together. This is exactly what we did in a recent phase 3 trial testing capivasertib, which is an AKT inhibitor in these patients with PTEN deficiency. It's called the CAPItello 281 phase 3 trial. It just reported its first readouts, and it's a positive phase 3 trial. Radiographic progression-free survival is statistically significantly improved, favoring the combination of abiraterone and prednisone plus capivasertib. More to come. The trial continues its follow-up, and eventually we will report long-term overall survival. Obviously, another emerging biomarker is about HRR, so homologous recombinations, DNA repair. Mostly BRCA2 for patients with prostate cancer, but also BRCA1 in a minority, CDK12, which potentially is targetable, and ATM, just to mention the most frequent. So why is that important? Obviously, because number one, this is a subgroup of patients with worse outcome, and number two, because we can target these cancers with PARP inhibitors, but also with platinum simply in patients who don't have access to PARP inhibitors. PARP inhibitors, I think, have delivered a beautiful job for patients with BRCA2 alterations, with probably up to 2 years of overall survival benefit in some of them when it comes to castration-resistant disease. We currently have also ongoing phase 3 trials for patients with hormone-sensitive disease, and for example, the Amplitude trial testing niraparib and abiraterone just provided its first readout recently with a clear benefit in radiographic progression-free survival. Again, too early to say for overall survival, and more phase 3 trials are currently underway and should report soon. A very small minority of all patients have an MSI high phenotype or a defect in MMR proteins that can be assessed either by immunohistochemistry or by NGS. I'm speaking about 2 to 3% probably. This seems to be extremely important to identify who these patients are, simply because these cancers seems to be very immunogenic, and they can benefit from immunotherapies such as PD-1 inhibitors or PD-L1 inhibitors, with long-term complete responses being reported for some of these patients. Unfortunately, we don't have phase 3 evidence for these rare patients in prostate cancer, but truly, clinically speaking, it is important to identify who they are because they really need an IO. And finally, the main driver of the disease for most patients remains the androgen receptor. We are just dissecting the biology of the AR in patients with advanced disease, including, for example, AR amplifications, which is frequent and associated with worse outcome, but hard to target specifically as I'm speaking. Probably more promising in the short term are AR mutations. Approximately 20% of patients that have exhausted androgen deprivation therapy and an AR pathway inhibitor. Those mutations seem to be very predictive from benefit from what I call third generation of hormonal therapies, those that appears to be working in patients who had exhausted abiraterone, enzalutamide, darolutamide, or apalutamide. So stay tuned, but I really think that we will soon use this biomarker in our practice. So please continue on to the next chapter with Professor Bertrand Tombal, titled Biomarker Testing in Prostate Cancer, Current Practice and What's Next.
So, hello everybody, welcome to this chapter titled Biomarker Testing in Prostate Cancer, Current Practice and What's Next. I'm Bertrand Tombal, Professor of Urology at Université Catholique de Louvain in Belgium. So, here the discussion will be much more practical. So, when do you test your patient? What do you ask? Actually, if you look at like the EAU guidelines, it could be the same for NCCN guidelines, they all recommend molecular diagnostic. As said previously by Dr. Fizazi, we have a series of candidates of choice, mostly DNA repair mutation, PTEN, PI3 kinase pathway, MMR. So we have a rough idea of what we have to test. But the question is when and to what patient. I think here we have to make 3 different groups. The first groups, and that's very important, is this what I'm going to call hereditary testing. As a young urologist, I was not trained to pay attention to family history. This is something in the last 10 years I've learned to do. I try to educate my resident as best as I can, that as any oncologist, we should pay attention because we are many times the front door doctor. We should pay much more attention to the family history of the patient. And also importantly, it is not only about prostate cancer, it is about cancer in general, with once again, very important, look for breast cancer, ovarian cancer, and cancer in general. That's very important. Because if you have somebody who report family history to 3 members in the family, you should refer that patient to an oncogeneticist because the consequences are much broader than just to treat the prostate cancer. They need to have much extended search for genetic abnormality. And we started that 5-10 years ago, and it's amazing. Very often we find people who come back with mutation, not necessarily for prostate cancer, but all form of disease. So I think that this should be part of basic urologist training. We are usually the first one to see the patient, so that's super important. Then the second category is what you do at diagnostic in what patient. I think that the group of patients with high risk localized disease, very high risk localized disease, newly diagnosed metastatic disease should get more attention from the beginning. In patient with ISUP 4-5, Gleason 8-9-10, we usually complement the pathology by a series of immunohistochemistry markers, quite easy to do: P10, P53, RB, retinoblastoma, AR. These are, and maybe Ki-67. These are important because unfortunately, has been shown like in the Capitello trial, if you have like metastatic prostate cancer and 95% loss of P10, 95% of your cells with a P10 loss, you get an aggressive disease, and in the near future, you're going to need a totally different approach. So that's what we do at diagnostic. I'm not going to repeat about PSMA because indeed PSMA is a biomarker, but it has become primarily the reference imaging technology to detect metastasis. So I'm sure it's done in everybody, even probably in too many people, but everybody with high risk to metastatic probably deserve to have a PET PSMA at entry. But on top of that, they need what I'm going to call enhanced pathology. And also, if possible, I would advocate in these patients to get, if possible, NGS to look for additional mutation, mostly HRR and MSI. HRR will become critically important with the result of the Amplitude trial. Patient with newly diagnosed metastatic setting, harboring BRCA mutation and probably other mutation will have a different pathway. So I think that if you're getting diagnosed with high risk, very high risk, and metastatic disease, then you should get at entry a PET PSMA, enhanced pathology under basic IHC. I do repeat, P10, AR, P53, Ki-67, RB. This would be my favorite. And then, if possible, to get an NGS at entry. Whether you order the NGS yourself or you work with an oncogeneticist, that's local arrangement. Whether you work on tissue or you get access to liquid biopsy, ctDNA, that's also local arrangement. It depends on the technology you have access to, but you should check at that point first. Then you've got the third part, the patient under treatment. If fortunately many patients will do well, many of them also will progress. And I really believe that every change in therapies in 2026 should be associated with a new PET PSMA. And if the patient had no germline mutation or no detectable mutation in MSI or HRR, it would be nice to recheck the patient and eventually, optimally, maybe get new tissue or ctDNA, circulating DNA. That's not easy. I would say in many patients it's not feasible right now, but that is where we have to go. I'm sure in 2, 3, 4 years we're not going to discuss about all of this. It's going to be automatic because as mentioned by Karim, if you are, for instance, progressing on ADT, the discussion about the next line of treatment incorporate a PET PSMA and HRR mutation. It has practical, immediate therapeutic implication. So I believe this is where you should check the patient. How do you do it? Once again, you do it on tissue, on or circulating cells. I would say both have advantages and disadvantages. It's not always easy to get fresh tissue, especially in patients with dominant bone metastasis. There's a lot of heterogeneity. It's not easy. Whether you should work in isolation or have a oncogeneticist on board, I would recommend the second, but once again, it's not important. But this is important that the patient is checked. This is the future of the treatment of this prostate cancer. Will not be science fiction in the future. It's going to be basic requirement for this patient. We need to find a way to get there, and we're going to make it there. So thank you for listening, and please continue on the final chapter, which is a panel discussion titled Best Practices in Multidisciplinary Care.
Thank you very much, and welcome to the third chapter entitled Best Practices in Multidisciplinary Care. My name is Alberto Briganti. I'm urologist based at Vita Salute University San Raffaele, Milan in Italy, and I have the pleasure again to discuss important and significant topics with the previous two speakers, Professor Tombal and Professor Fisazzi, whom we will discuss some important features for our everyday clinical practice. First, without any other additional discussion, I would like just to introduce the multidisciplinary tumor board members, because of course, as we deal with prostate cancer in our everyday clinical practice, we always take decisions together with a series of people that actually take part to our MDT. And these not only urologists, medical oncologists, radiation therapists, this is certainly an old vision. Indeed, we are asked to take more important decisions for patients together with many other people, including radiologists, cardiologists, pathologists, but also genetic counseling. And I believe this is very important for our discussion today. And of course, we do have many other people that take care of our patients in their pathway of care. So first, let's start with basic stuff about the differences between germline and somatic testing, because before speaking with our two eminent speakers, I would like to introduce some concepts and some data about the role of testing in localized disease. Being urologist myself, we are often faced with requests to test people whenever there is localized or local advanced disease in a non-metastatic setting. And we do indeed have guidelines about germline mutations testing, and I will start with that first. The main guidelines that I will touch upon today are the NCCN guidelines and the EU guidelines that actually suggest or even recommend the use of germline testing in some categories of patients, being the NCCN guidelines being a little bit broader in terms of recommendations. And the recommendation is to test with germline testing patients with high risk or very high risk localized or locally advanced prostate cancer, strong family history and early onset, or suspect hereditary cancer syndromes, and what to test. The guidelines indeed suggest testing mutations and some panels, including genes that you see listed here: BRCA1 and 2, ATN, CHEK2, PALB2, OXB13, and MR genes. The guidelines of the EU are instead a little bit more restrictive in terms of indications for germline testing in patients with localized disease, being these confined to few patients with strong family history and people and relatives with early death from prostate cancer. And actually, what you see here is the testing is mainly reserved to BRCA2 and BRCA1 and DNA repair genes in these men. What about somatic testing? And of course, somatic testing is related to the mutations that can be found in the tumor. And if you look at all these databases, including testing and positivity of testing in somatic tumor sequencing, you find that actually the alterations in HRR genes, including BRCA1 and BRCA2, which are of course the most common ones, especially BRCA2, are actually seen in 8 to 12% of the cases. So in a relative minority of these patients, being the mutations in MMR genes even less common in about 2% of these men. And what do we do if we have somatic mutations which are found when we do testing? Well, this is the question which is not yet answered in localized disease. And I think this is an outstanding trial testing the way we can actually modulate our therapies in the perioperative space based on individual somatic testing. And this is the GANS trial, which is up and running and which is led by Martin Gleave, which is, of course, doing something which is very smart. It's testing somatic tumor sequencing, and people and persons with different profiles are actually randomized to different treatments, and they're receiving different treatments based on RP doublets, mainly based on, of course, the genetic tumor testing alterations found. So this is the very first time whenever when we use or we can use and test the role of perioperative strategies according to individual patient's mutation when the disease is not yet metastatic. For the time being, apart from the GANS trial, what we can use are the so-called genomic classifiers, which are actually widely used worldwide, less in Europe, I would say, but the use of course transcriptomic signatures in the tissue coming from the specimen from prostatectomies or biopsy. And these genomic classifiers can be used to, for example, modulate different approaches in the postoperative spaces, or even use different timing of ADT together with radiation therapy. So they can be used to generally stratify patients according to disease features and aggressiveness. Well, having said that, and having in a way reported the differences in testing between localized and metastatic prostate cancer, I am now pleased to share this discussion with our two eminent colleagues. And I would like indeed to touch upon some important questions which are still there on our table, which have been touched upon by Bertrand and Karim already, because of course we entered the era of on individualized tumor testing, but also individualized therapies according to different genomic mutations that are found. So Bertrand, the first question for you, if I may, you were mentioning about the role of early testing, right? So let me just start with a clinical case of a patient of 78 years old with no family history of prostate cancer, but which is coming in the office for high-grade, locally advanced prostate cancer, clinical T3, Gleason 4 plus 5 or 4-5 plus 4 Gleason score, and with negative PSMA PET. So a purely locally advanced case without family history. Would this patient undergo any kind of testing in Brussels in 2026?
No, at the age of 78, with no family history, proven that it's already interesting, because I can tell you that most of the patient I see for second opinion, nobody never ask about the family history. So I would say that the urologist who saw the patient first did already a very good job asking about the family history. The second one is that at this point in time, although it has modest implication, okay? But honestly, it's a very high-risk disease. We know the patient may progress. So honestly, I would do what I said in my little talk, that we would ask on the pathology things like to be sure that the pathologist look at the presence of cribriform and intraductal, to ask P10, P53, and RB, because all of this, they point at very aggressive disease. And these are the patients that would progress very rapidly. We just saw a patient here who was exactly a patient like this, a little bit younger, 65. Patient did superbly well on AB plus ADT plus radiotherapy. And after 1.5 years, came back in a hurry for hemoptysis. The guy had diffuse liver and lung metastasis. And actually, looking back at the pathology, had P10 loss, P53 loss. So I think it is important that the urologist is leading that first look. And once again, if you have easy access to NGS, you should do it at this point in time already.
Thank you very much. So let me pose another question to you as urologist and seeing patients with also localized advanced disease. So we all have in mind the data by Elena Castro published a few years ago, and there have been some ongoing data reanalysis of these initial data. So we have heard that in some patients or in some series, having BRCA mutations may have these patients less likely to respond to radiation therapy of the primary tumor. So are you using BRCA mutations in localized or local advanced disease to decide whether you use surgery or radiation therapy in your practice?
I mean, the first question before that is, can we put BRCA patient on active surveillance already? So that's a question we have. I mean, if they have ISUP1 or very limited amount of ISUP2, it's not a problem. For the ISUP3, 4, we only have that data from Elena. So it is true that we usually, when we discuss with the patient, we usually have a very neutral approach between surgery and radiotherapy. But we always mention to this data, saying that to my knowledge, this is the only setting for which we have some level of data showing that surgery should be preferred. Okay. Likewise with the cribriform and all this move toward radiotherapy. So that's what we said to the patient. So I mean, these data are there. They are good quality. We're waiting for prospective trial, but we usually advise the patient, look, and it's especially true for the intermediate risk. No, if they have super high risk disease, we would say, no, radiotherapy plus AB is the standard. But for all the diffuse ISUP3, unfavorable, good prognostic, high risk, we say, listen, based on the Spanish data, if you're not afraid, we believe that surgery is a very good option.
Excellent. Thank you very much. So if I may, one question to Karim. So you actually showed in your presentation very compelling data on the use of different approaches according to individual and different mutations or genomic alterations. I mean, that as you were saying, can even be seen in immunohistochemistry. So what is the current role of testing, for example, in patients with recurrent disease, for example, after primary therapy? I mean, are we using or are you use your testing also to modulate the type of therapies you may do in the recurrent setting, knowing that these patients may have more favorable natural history? So rather than metastatic upfront, what about recurrent disease?
Well, I guess, starting from the beginning, I think we have probably level one now evidence that we should test all our patients with castration resistant disease, regardless as whether they had upfront metastatic disease or whether they had a recurrence after prostatectomy or radiation therapy, so recurrence after localized disease. So for castration resistant disease, we should test. Don't even think about what the presentation was. If a patient has BRCA alteration, is very likely to benefit and to benefit long, especially BRCA delete form as opposed to BRCA mutations. Also true probably for MSI high. Now, for patients with hormone-sensitive disease, probably a more complex view indeed. For patients with upfront metastatic disease, clear indications that the outcome is worse as compared to those who relapse after localized disease. So these patients should be tested. Also, they are enriched in patients with BRCA alteration, with PTEN alterations, etc., etc. So there is a clear case to test, I think. And the recent amplitude data are also supportive. Of course, pending we have approval and reimbursement for PARP inhibitors in this setting. Now, for patients with a relapse after local treatment, generally speaking, they do much better, and also they're much rarer in clinical trials. So the evidence is scarce. So we need to be cautious about all what we say, testing, but also treatment. This is true for systemic treatments, the role of RPs, the role of taxane, which, by the way, taxane are mostly out of the game for these patients. and the evidence for RP early use is debatable. I know some countries don't necessarily use them, at least in all their patients. And this also applies to newer treatments. Not even speaking about stereotactic radiation therapy, where we still need more data to support its routine use, at least. So again, relapse patients, first, we should tell all our patients that they have a better prognosis, so it's a good news. The bad news is that we have less evidence about how best to treat them. And as doctors, we need to be cautious, take into account their natural life expectancy, which is longer, their comorbidities, their choice, and everything. And most importantly, try to enroll these patients in trials so that we can really learn how best to treat them.
So thank you very much, Karim, and thank you very much, Bertrand, for this great discussion. I think that now time is over, and we would like to thank again on behalf of the entire panel for this great discussion and again for participating in this great program. Thank you very much.